Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it. All right, we are back again, this time with another March-related topic, because March is National Athletic Training Month.
Yeah, and we've teased a guest now for like 12 weeks.
Yes, yeah.
Every time we're like, we should get a guest.
Yeah, last week we teased a guest that didn't contribute.
That is true. That is true.
Scout,
yeah.
Okay, so we have Brandy here with us. Brandy, why don't you introduce yourself? Tell us who you are, what you do, your life background, your story.
Oh, okay. That could be a lot. We'll keep it simple.
The brief version, I guess.
Cliff notes. My name is Brandy. I'm an athletic trainer by trade. I do more administrative things now in my role. I work at an EHR company, but have lots of athletic training experience. Started out more traditional and then moved into the physician practice setting. So yeah, I'm excited to be here.
I love it.
And you are a very good example of someone who's worked in various like geographical settings, right? So sideline medicine, academic world, physician extender, and then now more administrative, which I don't think a lot of athletic trainers can speak to that.
Yeah, I've breached all of those.
Yeah. So we eliminated all of our subpar athletic trainers just to get you on here today.
God, we love that.
Elite.
I love that. I'm going to write that on my resume.
Brandy, do me a favor and define what an athletic trainer is and how it is not a personal trainer.
Yeah. So that's a great one, because athletic training is a little bit of a misnomer, right? So people think personal trainer, fitness, that sort of thing. And so we touch on that a little bit, but basically like within our realm, we're like a musculoskeletal specialist. So we kind of bridge the gap between injury and then recovery. And then specifically as it relates to like y'all's world, in the physician practice setting, we are extending the provider, and that could be a PA or that could be, an MD, a DO. But the goal is, improving access, managing patient care and flow, guiding patients safely back to function. And then a little tidbit, again, not really related to what you guys do, but we do work across healthcare. So we work in lots of other settings too, like industrial setting, public safety, military, that sort of thing.
Can work in primary care. It doesn't have to be ortho.
Yeah.
So it's interesting because I feel like when I was in school for athletic training, did they touch on with you at all like the orthopedic clinic setting much, or were your routes kind of like you're either going to work in a high school or collegiate setting, or eventually, an educational or work in a teaching type setting?
So I think that my program did a good job of exposing us to as much as possible. So like the industrial setting wasn't as popular, the military or like public safety wasn't, but I think I got a pretty well-rounded experience as it relates to like what were the more like prominent settings at the time. And I think for me, like I always knew like I wanted to like have some fun and definitely do the traditional athletic training things, but like long-term didn't see myself like staying like in that world specifically.
That's a lot.
Yeah,
it is.
So your undergraduate training, that was your degree is in athletic training, is that right?
Yeah.
Okay. So anatomy lab,
all the
biology,
things, cadaver lab, all the things. Yeah.
Okay. So I think any undergraduate candidate that is interested in doing something in that world, I think it's got a lot of the same foundational things that PAs will have, right? So interestingly, I think we do hire a lot of PAs, and I think that it is attractive to me when a PA has an athletic training degree, because you're kind of brought up in that science math world, right?
Yeah. You get a lot of the exposure. Now, I will say now with the master's situation, like that's a little bit more touchy of like a subject of rule, like deciding how to, up your education level now that they switched it to a master's. When I got mine, it was just purely a bachelor's degree, probably yours as well.
Yeah,
but then you got your master's afterwards. But now in order to just become an athletic trainer, you have to get a master's degree in it.
Yeah. So I think that I think that's pretty common with PT too, but that person or that type of employee that's duly credentialed, whether it's PT AT or PA AT, I think they're eventually going to like disappear, which is interesting. I don't know if it's
Yeah.
good or
Yeah.
bad, but
I disappeared.
disappeared.
Well, my AT did.
No, you're
And I
forever an
see you.
AT. Yes.
Still in existence. But yeah, no, I mean, there's a lot of crossover with it. I think it's like a really great, not just side by side, but segue into that career type of role. So, yeah. So let's talk about why athletic trainers are great in this setting and other settings, and why orthopedic surgeons like to work with athletic trainers.
I think athletic trainers, just in general, as far as their availability to orthopedic surgeons, I think they are, let's say you have an athletic trainer that works at a high school, that works for, a semi-professional league or professional league, like that, you're a liaison, right? So you have your hands in communication with the school or the, athletic facility, and also you have direct communication with the physician. So you are a very nice liaison for access for an orthopedic practice into Pop Warner football, into
the community,
high school sports, into the community. So I think orthopedics practices in general find it very appealing to have that person.
Mm-hmm.
So talk a little bit about what your training looks like and why you think that means something in the orthopedic world.
Yeah, so all of our training starts out like with a musculoskeletal mindset, right? So like I had to take a what's the word I'm looking for? Like I had to take a pharmacology class. I had to take a gen med class where I learned about ringworm and all that other gross stuff.
Gross.
But so much of our training is specifically like musculoskeletal specific. So that goes hand in hand with orthopedics in general, right? And then again, we're segueing, like the patient gets hurt on the field in a traditional sense, right? Or the patient gets hurt in a factory somewhere, whatever. We're segueing that happening into them going to see the next provider, whether that's a PA or MD, DO, whatever. So we're bridging the gap, right? And so we're saying, hey, like this is what happened. This is how it happened. This is what I think. I'm handing it off to you, and then you guys have access to things that we don't always have access to, like advanced imaging, can't write a prescription on my end, that sort of thing.
Yeah. I think like from my perspective, doing both my athletic training coursework prepared me better in many ways than like my PA coursework. I mean, it was 4 years of MSK orthopedic focus versus 2 weeks in PA school of MSK orthopedic focus. Now, from the PA perspective, you're definitely getting more of like the why and the medicine aspect of things, procedural skills, stuff like that. Like there was a ton. I feel like I was able to build off of everything I had already learned in athletic training once I was in PA school. But I came into it with such a broader knowledge base of ortho and MSK section than anybody else in my class, other than the 2 other athletic trainers that were there.
Well, I think when I interview, nurse practitioners or PAs, when I see they have an athletic training background, I'm like, oh, okay. So your ability to injury eval is 10 times better than any other run-of-the-mill PA that did
or
2 weeks of ortho or read
or
a book or something like that. Yeah. The orthopedic special testing, that type of stuff, it's not the first time you hear it because you've probably done it already.
Yeah.
I do think the difficulty when I see an athletic trainer that is now a PA is the what's next steps, because you can tee it up and get it into the physician or into the orthopedic practice, but reading the x-ray, what type of brace do I use? How quick should I get this to the surgical team? Like that type of thing. Or, are they non-weight bearing for 4 weeks? Or can they weight bear with this? DVT
I'm making those decisions now on top of it.
So that's the learning curve with, former ATs that are now PAs. But all the eval stuff, I feel like is spot on. Much better than PAs.
And this is kind of something we touched on in the outline. I want to see what you think about it. But we were talking about loyalty to the surgeon system. And by that, I think we mean their protocols and the way that they like to do things specifically, right? Like, oh, I like to brace this, or this is my rehab protocol for X amount of weeks, versus going off and doing your own thing. I mean, I don't think that's an issue personally, fortunately, that we struggle with at all here. I think it's more from the outside athletic trainers working with, communicating with a surgeon that they're not working directly with every day.
So I think that, like, and it varies a little bit state to state, but, athletic trainers work under the direction of, or at least in collaboration with, an athletic trainer or with a physician. So for me, I have a protocol that's signed by, what do you guys call, what's his code word?
The captain.
The captain, right? The captain signs my protocol. Yeah. So, I need to be in alignment with the captain. The captain has to feel good about, like, what I'm going to be doing when he's not around, right? Like, he has to trust me. I have to trust him. And so you do really, he's not going to just sign anything, right? So you do really have to have, like, a good working relationship. But with that, it really does come, hopefully, like, a better understanding of, like, how they do what they do, or why they do what they do, or what their philosophy about X, Y, or Z is. And then you guys are working together to, make that become a reality as it relates to, like, whatever patient is coming in, or whatever injury it is, or that sort of thing. So, I think that loyalty kind of is a little, it's natural, right? But because it's like,
yeah, because it's mutual trust.
Yeah, the way the way they structured it, right? And again, it's a little bit different state to state, but in the state that we're in.
Do you feel like you had to prove yourself to the previous surgeons that you have worked with?
Yes, but I feel like I have to prove myself to everyone.
Well, this is just a universal.
Well, I guess what I'm saying is I think, and again, I can't speak for an orthopedic surgeon, but there is a basic level of trust that an orthopedic surgeon places in an athletic trainer. Mm-hmm. However, being on the clinical side and hearing the surgeon say, well, this one's too aggressive and this one is not aggressive enough. Mm-hmm. Like, do you feel like you had to demonstrate your ability in order for them to
this one's just right,
to reach out
the
to
Goldilocks?
You? That. And then also too, like, I think like my protocol, like, and we can touch on this in a little bit, but my protocol looked different than some of the other ones because I had different skills. But, like, we had to sit down and be like, hey, like, I'm going to be doing this. This has to be added to my protocol. Like, are you okay with the wording? Are you okay with the verbiage? Like, what does this, we got to be on the same page because at the end of the day, like, you're signing this, right? Mm-hmm. So there's lots of conversation that maybe people don't always know. And there's definitely, like, standard of the meal ones too, where, like, if you're only going to be doing more traditional athletic training, maybe you don't feel like you need that as much. But I think the more advanced your skills become, the more that, becomes a pivotal part of the relationship.
Do you think that you have seen certain skill sets in more experienced athletic trainers that you could say are more, like, likely to be successful? Or do you feel like for example, your personality, do you think that you could just exist doing mediocre things and the physician would be like, okay? Or do you feel like you have asked, like, oh, I can do this, let me show you. And now I can do this, let me show you. Like, do you think that does that come with time? Is that a personality thing? Like, what differentiates some athletic trainers from others in definition of success?
Yeah, I think some of that is definitely personality. And I think some of it maybe too is, like, there's certain personalities that are attracted maybe to different settings of athletic training, just like there's different personalities that are attracted to probably different types of medicine or different specialties within medicine. But so I think some people are okay being, like, more of, like, a jack of all trade, right? Like, they have a lot of broad skills. I liked that, but I also was like, no, I really want to, like, be a little bit more specialized, right? Which is, like, what was really attractive for me, like, being in the physician practice setting of, like, okay, I'm going to narrow a little bit, but, like, what I get to do if I can push the envelope and find a provider that will really support me in a team, I can go a little bit deeper into what I'm doing on a day-to-day basis versus maybe just, taking care and then getting to the next point.
Or, like, sense. Sometimes personality-wise, in the traditional setting, collegiate or high school, a lot of, like, I don't want to use the word independent thinkers because I would like to think independent thinkers, but you are still working under a physician's protocol, but you are your own you are the head decision maker in that sense, right? You're creating.
We're not calling the doctor every day and saying, like, hey, here's everything that happened today while I was in the field. What do you think about it?
You're managing your protocols. You're managing, like, you have your own EMR. Like, you are your own manager. Yeah. And so I think that is desirable to some people, just like that independence level with it versus, like, the
space is much more collaborative.
Yeah.
For sure. Yeah.
And then, I don't really have much experience to speak on for some of those other interesting roles like the industrial settings and whatnot. But yeah, I think a lot of it depends on that aspect of personality too. Like, do they want to be super, super collaborative? Do they like to be their own boss, so to speak, right?
Yeah, I definitely think one probably overarching theme is they probably all got into it because they enjoyed sports in some sort of aspect, right? Like I think that's definitely.
Did you play sports?
I did.
Okay.
Listen, tore my ACL playing basketball. That's the pivotal moment that started all of this.
Oh man!
Yeah.
See, we were just talking about this earlier. Like, yeah,
Like I think you as an athletic trainer going through personal athletic injuries, that holds more weight.
Oh yeah, for sure.
Than your hypotheticals, right?
Mm-hmm.
I just think that someone is going to listen to you a little bit more so than the next person, specifically because you've been through some stuff.
Listen, I've been here.
Yeah,
when I've done that, I get it.
I know what it's like to tear your ACL and have to do rehab. Yeah.
Gosh, how many people in this office are left to tear their ACLs? Next, good Lord.
There's more left than there is those that have, but give it time.
Give it time, and we'll all be added to the list at some point. Now, better watch out.
Brandy, making your transition to the clinical side, okay? And now I've been in orthopedics for about 20 years. Athletic trainers, in my experience prior to coming here, we had a DME coordinator that was an athletic trainer. I feel like that's a very good,
that's a cool
transitional thing, right?
Yeah.
You had entered our practice being the head of the athletic training residency. Okay. So the orthopedic practice that we work at had an athletic training residency where we take athletic trainers, they apply to the program, and it's 1 year of working as physician extenders. So one, your intro into that, I guess I'll call it academic, but it was clinical. Like you with the academic and clinical hat, what was the biggest shift that you saw on the clinical side that you thought, was different than your expectation, right? So athletic trainer working on the field, contacting the surgeon, then now you're behind the scenes. Like what surprised you the most about that?
I don't know if I was surprised, but I think the biggest learning curve was like the business aspect of it, right? Like I think like when I was working, I did Division 2, Division 1, but like if I thought a patient would benefit from like an ultrasound treatment or a laser treatment, I just did it. Right? Like I didn't think about
insurance
or will we get reimbursed for this or is this worth my time?
Yeah.
I was just like, clinically appropriate, I think has therapeutic, like positive therapeutic
benefits
things for this patient.
Might as well try.
Might as well try.
Yeah.
I got the time. They got the time. So that like that mindset shift was, I mean, not bad, but just like, different, right?
I think that surprises PAs coming out too. Yeah. Just the business.
Yeah. I think also like, because you have to do, and your athletic training residents had to do a fair amount of documentation. I think that I don't think that that's communicated very well in PA school, how much you have to document. Did you see anything on your end that was like, oh, that's important, I have to write that down?
Yeah. Like I think like the idea of like, we definitely document in athletic training, right? But I think, again, we documented what we did because that's what we did versus we have to documenting. And I never thought like I need to document this or I need to make sure this specific sentence is in my note because if I don't do it, I'm not going to get reimbursed. I don't have to specifically say that the patient has tried and failed conservative treatment, blah, 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 blah. Yeah. I'm just like, this is what we did today, right? This is what they came and told me. This is what I saw objectively. Here's my assessment plan. This is how we're going forward.
So much more logical.
So much more logical.
But that's not a level 4, Brandy.
It's not a level 4. And if you don't put this one sentence in there, then they're going to deny whatever's coming next. They didn't take aspirin for 7 days first to see if it helped. Yeah.
Did you demonstrate any more appreciation for like what the surgeons have to do? Because I feel like, again, from an athletic training standpoint and from your communication with surgeons outside of that, it's kind of glamorized, right? Like they see an injury, I tee it up, they get it, and they just have to fix it. But you see all the other stuff, right? I mean, the surgeons are just not operating. Like on the clinic days, they're seeing stuff and convincing patients why it's not surgical, and then convincing that it is surgical, and then talking them through risks, and then dealing with the parents. Like, did you gain any more appreciation for the surgeon role?
Yeah, because I think, in our role as athletic trainers, like we get to know our patients really well, right? So like I didn't really ever have to do a lot of convincing because I had like a personal relationship with each one of them, right? Like maybe there was some like harder conversations with parents or something, right? Because I was working with like adults that were 18 and didn't need mommy and daddy all the time. But it was very interesting to like be in a room with a physician and convince the patient that was like convinced they had something else and they came in that it's not that, right?
Mhm.
Or they were so sure they needed surgery and they're like, actually, there's a really great conservative option for you. Like, we shouldn't start out with surgery. And then for that patient to get pissed because it wasn't what they wanted it to be. So, like, I think, like, having an appreciation for, like, one, like, that's really cool that we get to have that relationship, so it makes it easier. But two, like, like, navigating that when you don't is a lot trickier.
Yeah.
And takes a lot of, like, skill.
Yeah. So,
now, as far as orthopedic surgeons and athletic trainers, okay, so this is kind of what I really wanted to talk about. You have, and again, this is, me to Brandy, but me to Hannah, like when you are working with a surgeon, you kind of get their protocols and when they want to see someone, right? Like you can see a patient, they injure themselves, whatever, practice or a game. You're going to send them into the surgeon when you think they need further imaging. You think they need a better exam. You think they need more treatment than what you're capable of doing. So insert the PA into that. Like how working as an athletic trainer, but then also working as a physician extender, like where does that play in? Like, what was your impression of PAs? Did you like them? Were you like, why is this person getting in my way? Like, what does that do to the dynamic with the surgeon?
I don't know that I've ever felt like PAs were in the way. I feel like I definitely have had circumstances where I feel like the PA was like felt that I was in the way or I was taking something from them. But to me, like, I mean, I would in our practice, right? We were really fortunate that I would refer to a PA just as quickly if I could to an MD, especially if the MD wasn't available and I knew the next step was imaging. You can order an MRI just as well as they can. So why wouldn't I let you tee that? You know what I mean? Like, because again, like at the end of the day, it's like, are we taking care of the patient well? And then that's all that really matters to me. So I don't know that I ever like had my like personal feelings of other than like if I felt like they had strong feelings about me or my role, like how do I like navigate that, but I personally never felt like, I would never send a patient to a PA first. Like that was never really my thought process. But
I have seen like some athletic trainers or worked around some who do have that mentality that they're like, ooh, don't see a PA. Make sure you see
the surgeon,
somebody else, that don't have that trust.
Comes with like understanding like the dynamic between in my previous role here, I had to explain that to patients a lot. I only want to see the doctor, and I'm like, if that PA is on that doctor's team, like they're like how they do things,
of them.
they're
collaborating.
They're another like another extension of that provider. There's no way that they're going to do something that like would completely negate what the doctor would like. They're going to be on the same page. If the PA had a question, they'd consult the physician before they. I was like, you're getting the same quality of care. In this case, you really want a quick appointment. The first available is with the PA. Take it or leave it. It's up to you. But I promise you, like, your care will be equal.
Do you think that your communication with PAs is easier or they're more available than the surgeon, or is that very completely dependent on surgical
I think that's probably
and
completely different. And I think too, like how long has the PA been on that team? Like what is their experience? Like I think with like you guys, like I think that was always really easy. I think like maybe like some of our newer like urgent care providers that were newbies, and a lot of times I knew more about musculoskeletal stuff than they did. Yeah, my approach would be different. So it really depended on like the dynamic of the team. But for sure, if I walked by your pod and you were there, okay, cool, Beth's here. That's who I'm going to talk to about whatever this patient is.
Now, as far as roles, right? So an athletic trainer in the clinic can be a physician extender. We employ a lot of athletic trainers as medical assistants. And I think it adds a next level of the HPI better. They can kind of guide their questions better. So they're a different caliber than just
rooming the patient.
And a medical assistant that, let's say, doesn't have ortho experience. So I think, as far as a role distinction in the medical assistant setting, I think that's, they have the upper hand. But athletic trainers can do a lot of things, right? So like, let's say I'm checking out a patient and I want to go over exercises with them. Like either I'm going to do that in the room with the patient, spend 10 minutes, or I'm going to send you in and trust that you're probably going to do a better job than I do, right? Because you can employ home exercise programs. Some athletic trainers will do postoperative rehab with these patients. But more recently, and you can speak to this, athletic trainers can get their OTC. Is that right?
Yeah. So it kind of depends on the state, if they have to get an additional credential or not. In our state, it just made it easier. So it was like a path of least resistance type of thing. And honestly, it has to do with credentialing more so than like skill. But yeah, so with that in our state, with that extra credential, like I was able to go into the OR and scrub in and for the most part function very similarly to a PA, right? Or like a surgical first assist, right? So very interesting experience for me because didn't get that training in school. So a lot of it was on the job training,
on the fly,
right?
yeah.
So, right. I mean, the test basically, I took a test. I basically, because I have my ATC credential, I could sit for the exam. I didn't have to like go back to school. I didn't have to go back to school. No courses, nothing. And to be fair, really didn't study for that. I mean, like I already had the knowledge, right? So the knowledge was there. Took the test, but then I was like, okay, well, now I can do this on paper, right? The hospital's credentialed me, but like. I never scrubbed in a day in my life other than like, I've been in the OR like but like never really like scrubbed in. So like, what does that look like? Learning on the fly, sterile technique, like all the things, right? Learned a lot by doing the wrong thing and getting yelled at.
Come on.
Well, that's how it happens.
Corrected strongly.
Yeah. All right. So, it's a strong word.
Yeah.
Word choices,
but did you ever see yourself or did you ever get that feeling that you were ever that animosity or?
I don't know. Maybe. I mean, everyone kind of just wants their own like space, right? Like, so there is like, like I have my niche, you guys have yours. So there is, I'm not trying to take away from anyone, but I do want to create space for myself, right? Like I really, enjoyed this setting. And so like, how do I create space for myself and get to, expand my knowledge and skill and ability in a way that benefits me, but also benefit the practice and benefits patients and that sort of thing. This is probably a topic for another day, but I honestly feel like I probably stepped out. I felt there was more of a threat from people in the like OR suite, like those people. Probably there was much more friction than like the PAs themselves.
Yeah, but I think though, if you're, let's say the OR, right? So you're first assisting, and let's say you're doing it because you want to. Let's say you're doing it because we need you to, right? Or let's say you're doing it because you just want to gain experience.
You volunteer too on a day
on a
that
day.
Somebody is needing. Yes.
But I mean, it's really hard for those, not the surgeon, not the PA, but let's say the pre-op PACU or the scrub techs, right? It's hard for them to place you because at least Hannah and I, when we're in surgery and then we're out of surgery, like we're calling patients, we're doing this, we're doing that, like we're doing other things that the nurses can come ask us to do. And here you are, and they're like, "Hey, I need you to put orders in." You're like, "Oh no,
I actually can't."
Yeah. Or like, "Hey, I need you to send this prescription." You're like, "Oh,
can't do
that." And that, I think you were met with a little bit of like, "What's her problem?" Versus like, let me give you my laminated form of what I can do, so don't hold me responsible for that. So I think there's a little bit of role blurring there, but not necessarily. In an animosity.
Yeah, and then so much
way.
of that goes back. I mean, there are some states where like athletic trainers have standing orders to be able to do some of those things. Like in that setting, the physician has to sign off on it.
But you can be delegated, right? And we even can do that, right?
Yeah.
Like especially for non-controlled things.
Yeah.
Like
so
it's
really, again, it's state to state. Yeah, but I think I was more successful. I don't know. In some ways, I think there was some like, especially like closing a wound. Like there was some friction there. Why can she do that and I can't? And I'm like, well, like my state practice act says I can. I have this extra credential. Like my credentialing at this facility says I can. Like the doctor has signed off on it.
I've done it before.
I took courses to check.
Yeah. And I think, again, you kind of broke the mold, at least at our practice, with doing the next thing because you wore the admin hat and you could do the medical assistant thing. And then you were administratively running certain departments, but also you're scrubbing in. Like, I think, if you're an athletic trainer looking at this, like that's through how many years of experience?
Oh, let's see. I got certified in 2010.
Yeah. So I mean, we're talking, this is not a new grad situation.
No.
But I think you also have to demonstrate competency and gain the respect of the surgeon, not just as an athletic trainer, but also as a competent individual that we want to use on our team.
Yeah.
I do think when you have a physician assistant who's trying to define themselves and then you have this other person who's super capable, I think that can cause a little bit of friction, but again, personality dependent. I had a medical assistant that was an athletic trainer that came very capable. Like he said, he can do all the things. And I wanted to watch him do the things to make sure that I trusted him. And turns out he did a shitty job, right? But I mean, that led to a very unfortunate situation where he said, "No, let me." And I was like, absolutely not. Listen to me. Let me tell you how I want it done. He was like, "I don't need you to tell me how I want it done." Like that was an example of that didn't work out.
Yeah.
An example of how things can go poorly.
Yeah, but I think in the right setting with the right person, I think athletic trainers as physician extenders in various roles in orthopedics, great. Super supportive of that.
Yeah. Don't put me in women's health, right? Don't like, there's plenty things like, don't put me there. I will not thrive. But yeah, orthopedics, even like family practice a little bit.
Yeah, because there's some.
But yeah, not everywhere. We don't belong everywhere, and that's okay.
Yeah.
We're not trying to belong everywhere.
Yeah. I think that was the goal of the residency program too. I mean, at one point when it existed, it was to kind of like create that space and try to find out where people felt like they fit or how you could fit into multiple roles at once. Because I mean, and I'm not saying that this is ideal necessarily, nor did you probably find it ideal, but wearing like 20 different hats at once. And I mean, you're simultaneously like still doing sideline coverage, administrative things, insert 10 other things.
And
right?
I think our practice is, I mean, we're not small by any means, but we're small enough to where like we still do that. I mean, I did that last Saturday, right? Like I still do that to kind of like, keep my hands dirty per se. But I think in bigger practices, you don't have people like that are still doing sideline coverage and in the clinic and that sort of thing. And that's tricky too, to like kind of like people probably tend to transition into like physician practice setting or this sort of thing because they want to narrow down a little bit. And so navigating that, but also meeting the needs of the practice or whatever else it is, you got to find balance in all of it.
Yeah, and we have athletic trainers. We have one who used to work on our concussion specialist team. A lot of them, we've got 2 that work on our sports med team, 1 on our hand team, 1 on our spine team.
There's joints team.
One on joints team. There's a lot of niches that these athletic trainers can fill. And again, if you're a female and you want a family, it's not, you're not on the bus with the high school team.
Yeah, I mean, there's some
like,
balance that can be found in this setting that cannot be found in traditional Division I.
Yeah. So I think that, for those looking to see what clinic life is like, I think you both of you guys can say that probably, made you well-rounded and introduced this whole other idea of what athletic trainers can do.
Yeah. Yeah. I think there's just such a plethora of things that going into it, you're already so much more experienced in, and like that you can hand off trust wise, like doing a large majority of the note and documentation and things like that. A lot of the like we didn't even talk about like casting and splinting and things like that. Those are all things that we learned in school too.
Where, like the athletic trainer sees a lot of the follow-ups in clinic by them. Like, again, the physician or the PA is there, but they're seeing those patients. They see the simple, non-complicated post. They're doing a lot of stuff that's like taking pressure off of the PA or the physician that either allows them to see more patients, which is good for their practice, or just allows them to not be burnt out. I mean, I think there's lots of correlation. There's lots of studies on physician burnout and adding an athletic trainer to the team and how that
always
changes the situation of that.
I love when I leave a room and I'm like, don't have to do the IM injections or something like that.
Yeah, procedural stuff.
Yeah, even when I worked in the urgent care setting, right? Like the difference between working with an athletic trainer versus a non-athletic trainer who can order the appropriate imaging, right? Somebody who comes in the room and already evaluates them and is like, I actually think it's coming from their back and not their hip because they did these tests and asked the right questions initially and got the right x-ray because of that, or neck versus shoulder thing, whatever. And then, so that part is teed up and easier, can do the injections and, does the HEP or, all the splinting and everything.
You're taking off a lot of the burden of the provider so they
and then you can see more people, right?
Yeah. So
quicker.
And I mean, there's lots of studies too that show that like patients like feel like they get the same quality of care. There's lots of studies that like, as it relates to like musculoskeletal stuff, like athletic trainers get the same diagnosis 98% of the time as a doctor. So I mean, we it's our area of expertise. So letting us contribute to that, everyone benefits.
Yeah.
Now, as far as like future goals for yourself, what your experience as, Division II athletic trainer, clinic, administrative, now in your new role, doing, even broader scope of learning about EMR and applying your knowledge to the rest of the world? Like,
Yeah.
what else is in store for you?
Yeah, that's a good question. I mean, I think that it's been fun so far to really contribute to like EHR business. Like, I definitely am contributing like from a clinical perspective, right? I think I'll always be an athletic trainer. I'll always have my hand in it. Again, like I still do some more traditional stuff. I'm staying credentialed, both from like, could I jump into clinic one day if you guys needed me? Could I jump into the OR on a weekend if someone adds a case and their PA is not available? Like, yeah, so definitely keeping all those things like where they need to be. I don't know that I ever see myself going completely back to like even like in the physician practice setting, like being on a team and doing that. I think I always enjoyed the administrative stuff enough to know that like I wanted some of that in my life, and so we've kind of shifted pretty far to that. So we'll see. But I really can't imagine a world where I wouldn't be attached to athletic training and specifically like physician practice setting in some sort of capacity. Yeah.
Yeah. Cool.
Yeah.
How fast can you tape an ankle?
Oh my gosh, so fast. And I could probably do it blindfolded. So
blindfolded. That's what we have to do our beer Olympics.
Let's do it.
Blindfolded beer Olympics.
We used to do AT Olympics in undergrad. There was no beer involved because that would have been, frowned upon.
I mean, depending on the
we're really, we're real
sense.
adults. Yeah, we're real adults now. So
Yeah.
it's fun.
Yeah. No, that sounds great. Is there anything that you wish the athletic training occupation offered you that you don't have?
I think that something that's missing is like, and something that like, there's discussions about is like being able to like actually like bill for our services. And there's lots of athletic trainers that have like they own their own clinic and they do cash pay, right? So like that is thriving and that's alive and well in our profession. But being able to like from a CMS perspective, like like being able to
recognize me as a worthy provider,
recognize me in a different but equitable way that you do PT or PA or pick anything else that's like comparable. I do think that would push the profession forward in a different way than we've been able to push forward so far.
Yeah, because I have seen like athletic trainers open. I don't know that I call it practices necessarily, but like businesses where they're contracting out services, right? They hire other athletic trainers that are then
a lot of them
covering
do like
schools
very
or whatnot.
similar to like cash pay PT, but it's cash pay athletic trainer, and they're doing the same thing. And honestly, like in some ways, you can feel better about that because that athletic trainer is working like underneath a physician, right, in some sort of capacity. So, what they're doing is, right and makes sense. But yeah, so that's cool, and people have found that niche, and they've been really successful. I don't know that would ever have been for me, but I would love to like have the opportunity to explore that, but maybe in the framework of like what medicine currently looks like, which is, third party reimbursement.
Yeah.
Is there any advice that you would give to an athletic trainer looking to get off of the sideline? Like, where do they start? What type of skills should they highlight when they meet with a physician team?
I think the biggest thing is like that we're multifaceted. I think we get so stuck on like some of the things we can do, some of the domains of our profession and not all of them. I think another one too is I think a lot of like older athletic trainers will tell you if you transition out of something that's traditional, you're not a real athletic trainer anymore. I use my skills in a lot of different ways every day. Like I could never touch a patient or an athlete again, and in some capacity, I would still feel like an athletic trainer, if that makes sense. But so I just like the naysayers, like don't give them a lot of credit for that, because like that was their journey and that's really great, but there's so many opportunities and everyone needs to do what's best for them as far as like what they want their life to look like.
Yeah, a real athletic trainer.
What is that? What does that even mean, right?
What does that even mean? Yeah, if you're not on the sidelines, like murdering yourself.
Working 80 hours
then you're
a week,
not
then,
real. Yeah.
Well, if you don't have like a crossbody bag.
You don't have your fanny
the fanny pack, the dry fit polo, and khaki pants.
Khaki pants. Are you a real athletic trainer?
Well, I don't, and I'm not.
Stop.
Do you still have khaki pants?
I maybe own perhaps one pair. I'd have to go look in my closet.
I think you do. It sounds like you do. It sounds like you definitely have
not
some
in like the traditional sense of that.
Or a pair of like smart athletic shoes that you can run in at any point in time.
I mean, whatever athletic shoes I have are the ones that I like wear to the gym or do whatever else. And I don't have shoes that are specifically for athletic training, and my fanny pack is a crossbody, and I've had it since undergrad. So it's still kicking and living its
I
best
love that.
life,
You don't have
so.
like the big Mueller bag anymore.
I don't. And apparently all the rage now is like hard.
It's the hard shell
yeah.
cases. Dude, and last time I covered a game, it was like this massive
caboodle.
Yeah,
Like,
exactly.
I was like, what
Like a caboodle.
Yeah, and they were like pulling out different compartments. I'm like, holy shit, like my bag looked like a fucking disaster. Like there was just like pre-wrap and intertwined with like mixed up with everything else.
Yeah,
The mustard was exploded onto everything.
Last Saturday, I worked some soccer, and I texted the athletic trainer that I was covering for, and I was like, listen, I don't know about this hard kit life, but I was like, this is awesome. Like, we didn't have any of this shit when I was doing this before. I was like, it's so organized. It's so great.
So organized.
Final question. What do you feel about a gator? Like, how fast will you take a gator?
Oh man, I haven't driven a gator in a long time, but we were like back in the day, we're whipping that, whipping that thing around.
I mean, that would be a perk.
That was like the number one benefit to me personally was driving the gator.
When you were a student, getting to the level where they trusted you to drive the gator, that was an accomplishment.
Yeah. You felt cool. Like you were driving around campus and you were like, I get to drive the gator. And in my mind, I was like, people are looking at me right now thinking I'm cool. I'm like,
so
nobody thought that.
Janitorials. No. I covered one of the high schools, and it was a massive like busy game or whatever. And my two kids wanted to come with me. So I was like, oh my God, I'm not going to get there for the start. So I parked like way far away. So I texted the athletic trainer and I was like, hey, is there any chance you can come get me? And she's like, I'll be right there. So she pulled up in the gator and my kids got in the back and they were like, that was the coolest thing. Like, why are you not an athletic trainer? I'm like, that's a great question. Like that's stuff.
Like, I just want to ride the gator.
Like a core memory for them.
Yeah.
Huh?
Yeah. Core memory. It was like off-roading and like, nobody asked any questions.
Oh my God.
VIP.
That was what really appealed to me. Yeah. When I was in high school, I saw the gator whip around the corner. Actually, we only had a golf cart for the first couple of years.
Abandoned and I'm in.
Maybe I should just like live in one of those golf cart communities.
Yes.
Yeah. Like where.
Yeah. You'll be driving around like, she was an athletic trainer.
Yeah. Like with my visor.
Look at that 3-pointer.
Yeah.
She knows what she's doing.
Amazing.
Nice. Well, thank you,
love
Brandy.
it. Yes. Well, we were talking about the fact that once you're more established in this, you'll have to come talk to us about the inner workings. The other side of things.
The dark side.
The dark side.
Well, hopefully the goal is to do things to make it easier. You're curing complexity. That's the company that I work for. So that's their motto.
I want a shirt that says that.
Yeah, maybe we should.
Curing
complexity.
Yeah. So
also, I appreciate that you wore your Backstreet Boys shirt today.
Yes, absolutely.
I noticed
Brandy was my Backstreet Boys.
Yes, Backstreet Boys. We
Backstreet
did it
Boys
together.
buddy.
Yeah, and I paid way too much for this shirt not to wear it regularly.
Yeah, no. That's
it
once
was,
a week.
Dude. Merch prices at the Sphere. It was insane. But after a
we
couple
did it
of
for the
cocktails, when you're like, you're there and the experience is overwhelming, you're like, I will pay anything to wear this Spirit jersey.
Once you're gone, you can't. Yeah, it's too hot for a Spirit jersey today. Otherwise, I would have that one on. But it's for the men. And once you're gone, it's not available. I don't think you can order it online. So
I drink out of that cup very often because I'm like, wow, this was a life investment for me. Amazing. All right. Well, appreciate it. Until next time. And happy Athletic Training Month to all the ATs out there.
Yeah, care you can count on.
Is that the motto?
That's the theme of this year. Yeah.
Oh, I love it. Care you can count on. Can we put that on the back of the shirt?
Curing complexity.
Curing complexity. Care you can count on.
Wow. It's like a.
Can't wait.
Yeah. Tongue twister.
Perfect.
All right. Till next time.
Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.